What does it truly mean to be cured of a serious illness? Especially when that cure, well, it has its own complex unfolding story and introduces a whole new set of challenges we're still learning to navigate. It's a question that cuts right to the heart of modern medicine.
Indeed. It's no longer just about, eradicating the disease from the body. It's about the holistic, long-term journey of the patient, the quality of their life years, even decades down the line. This evolving understanding truly transforms the very definition of success in oncology.
That's a powerful transformation to consider. Welcome to the Deep Dive, where we take your sources, meticulously unpack them, and extract the most vital insights to make you truly well-informed. Today we are embarking on a crucial deep dive into a specific type of cancer that boasts, well, a remarkable history of successful treatment, yet presents profound new challenges that are actively shaping the future of medical research.
We're talking about Hodgkin's lymphoma. This is a disease that just a few decades ago was often a death sentence, particularly for young individuals in the prime of their lives. Yet through incredible, relentless advancements in scientific understanding and medical treatment, it now boasts astonishingly high cure rates. It's one of modern medicine's true success stories, but like all complex triumphs, it comes with its own set of nuanced realities.
Our mission for you in this deep dive is to go into every corner of this topic. We want to help you master this information like the elite professionals in the field. From its intricate biological roots and the precise diagnostic methods that pinpoint it, to cutting-edge treatments and the long-term journey of survivorship, you'll learn to spot those critical details and truly understand the so what behind them. This isn't just about facts, it's about deep comprehension.
That's right. We won't just explore what Hodgkin's lymphoma is, but why it matters so much in the broader context of cancer care. We'll delve into the fascinating cellular interactions that make this disease unique and trace the therapeutic evolutions that have made it one of oncology's most celebrated achievements. But we'll also openly grapple with its complex legacy, the very real, often challenging, treatment-related issues that survivors face.
Get ready for those aha moments, because we're going to untangle this often misunderstood disease, separating its two main forms and understanding the nuances that truly distinguish them. It's a journey into both triumph and the ongoing pursuit of perfect care. Let's dive in. So let's begin with the fundamental definition: Hodgkin's lymphoma, or HL. At its core, it's a type of cancer that originates in our immune system, specifically from what we call mature B lymphocytes.
Right. Think of these B lymphocytes as specialized soldiers in your body's defense system. They're part of your white blood cells, and their job is to produce antibodies to fight off infections. In Hodgkin's lymphoma, some of these mature B cells go rogue and start multiplying uncontrollably. While it's not the most common cancer, it's also not incredibly rare. It accounts for approximately 10% of all lymphomas diagnosed annually. That makes it a significant lymphoid malignancy that clinicians encounter regularly, and its story is, well, truly remarkable.
It paints a very different picture from today, which is why understanding its historical arc is so crucial. Can you take us back to what this diagnosis meant before the mid-20th century?
Absolutely. To truly appreciate where we are, we have to look back. Before the 1950s, Hodgkin's lymphoma was, to put it starkly, a highly fatal disease. For young individuals who are often affected by this particular cancer, a diagnosis of HL carried a dire, almost hopeless prognosis. Imagine a time when an otherwise healthy young person could be struck down with very little effective treatment available. The landscape was bleak.
That's a stark contrast to today. But then came the breakthroughs, right? What was the first major turning point?
The first major turning point was the advent of extended field radiotherapy. This involved delivering radiation to larger areas of the body where the disease was present. It marked the first time we could offer cures for some patients, particularly those with early-stage disease. It was revolutionary, offering a glimmer of hope where there was, none before.
And then something even more profound changed the game in the 1970s.
That's when multi-agent chemotherapy was introduced. This wasn't just one drug, but a combination of powerful drugs working together. This significantly improved cure rates, not just for early-stage disease, but crucially, for advanced-stage disease as well. This was a monumental shift that moved Hodgkin's lymphoma from a largely fatal condition to one that was increasingly treatable and curable for many.
And the remarkable current reality. Today, we're looking at cure rates for Hodgkin's lymphoma that exceed 85%. That's an astonishing medical achievement by any measure. To think it went from being often fatal to highly treatable and curable for the vast majority of patients in just a few decades, it's one of oncology's biggest triumphs.
This success, however, brings us face to face with what we call the success paradox. With such incredibly high cure rates, the primary challenge has shifted dramatically. While we've become excellent at eradicating the disease, we're now intensely focused on managing the late therapy-related toxicities that survivors experience for years, even decades after their successful treatment.
And these aren't minor issues, are they? Can you elaborate on the most significant long-term costs these survivors face? What are the biggest concerns for them once they're technically cured?
It's a sobering reality. We're talking specifically about a heightened risk of secondary malignancies, meaning other cancers developing later in life, and significant cardiovascular disease, including heart attacks and strokes, often much earlier than the general population. For many survivors, these long-term side effects become the primary health concern.
So current clinical trials aren't just about improving cure rates anymore, they're also about something else entirely.
Precisely. Current clinical trials are now explicitly aimed at minimizing these long-term risks while rigorously preserving the incredible efficacy that has saved so many lives. This raises an important question for you, the listener, and for the medical community as a whole. What's the full long-term cost of a cure? And how are we innovating not just to ensure survival, but to ensure true long-term wellness and quality of life? It's a balancing act that defines the cutting edge of Hodgkin's lymphoma research today.
It's a crucial point, highlighting the ongoing evolution of cancer care. Now, as we delve deeper, it's vital to clarify that Hodgkin's lymphoma actually has two main phases, two distinct entities that fall under the same general umbrella. The first, and by far the vast majority of diagnoses, is classical Hodgkin's lymphoma, or CHL. This is what most people think of when they hear Hodgkin's lymphoma.
And then there's nodular lymphocyte-predominant Hodgkin's lymphoma, or NLPHL. This is a distinct, much less common subtype, accounting for less than 5% of all cases. While it shares some superficial morphological resemblance to CHL under the microscope, biologically it's actually more closely tied to the indolent or slow-growing B-cell non-Hodgkin's lymphomas, often referred to as NHLs. This distinction is absolutely critical because it impacts how we think about its nature, its behavior, and ultimately its very different treatment approach.
Okay, so for the main part of our discussion today, our focus will overwhelmingly be on CHL. Given its prevalence and the wealth of information, it's the primary driver of the Hodgkin's story. We'll discuss NLPHL in detail later as a separate entity once we've thoroughly covered the classical form. This will allow you to grasp the fundamental differences and nuances that define each type. But let's unpack this and dive into the roots. The epidemiology and biology of classical Hodgkin's lymphoma, or CHL. When we talk about demographics, the incidence of HL has remained fairly stable over recent decades. In the United States, for example, we saw around 8,480 new cases diagnosed in 2020. So it's consistent, but it doesn't appear to be rapidly increasing or decreasing.
And we observe some interesting patterns when we look at different populations. It's typically observed to be more common in white individuals compared to black individuals, and generally it's more common in males than in females. These demographic tendencies aren't fully understood, but are consistent findings across large studies.
What's truly fascinating to researchers is what's often called the bimodal mystery of its age distribution. Unlike many cancers that simply increase with age, HL tends to have two distinct peaks in incidence. One peak occurs relatively early in patients in their 20s, and then there's another later peak, typically in patients in their 80s. Why these two distinct peaks? It's a long-standing puzzle in oncology.
That late-age peak, however, does come with a crucial nuance that professionals must consider. While it's a true increase, some of that late-life incidence might be partly attributed to diagnostic confusion. In older patients, other lymphomas can mimic Hodgkin's under a microscope, such as anaplastic large cell lymphoma or T-cell histiocyte-rich B-cell lymphoma. So while it's a bimodal distribution, careful diagnosis is key to avoid misattribution in the elderly population.
Right. Now, within CHL itself, it's not just one uniform disease. There are actually 4 distinct subtypes, each differentiated based on how they look under a microscope, their histopathologic features. These are nodular sclerosis, mixed cellularity, lymphocyte-rich, and lymphocyte-depleted. They represent different ways the disease can manifest at a cellular level.
And these subtypes also show different prevalence depending on geographic and demographic factors. For instance, in the United States and other Western countries, nodular sclerosing Hodgkin's lymphoma is by far the most common subtype, particularly predominant in younger patients. Conversely, mixed cellularity or lymphocyte-depleted subtypes are more commonly seen in elderly patients, those with underlying immune compromise like HIV, and individuals in developing countries. Together, nodular sclerosis and mixed cellularity account for the vast majority of CHL cases globally.
And speaking of fascinating associations, let's talk about the Epstein-Barr virus, or EBV connection. Many of us have heard of EBV. It's the virus that causes mononucleosis. There's been a long suggested link between EBV infection and HL, with traces of the virus found in a significant proportion of HL patients, typically 20–40%. This has led researchers to propose that the virus might play a role in causing the cancer.
However, it's crucial to emphasize that for the majority of CHL cases, the matter of direct causation is not settled definitively. It prompts critical thinking. Is EBV always a direct cause or sometimes just a passenger virus in the cancer cells? What's particularly striking, though, is how viral oncogenesis, the virus directly causing cancer, appears to play a significantly heightened and more direct role in HIV-associated CHL. In these cases, EBV can be detected in nearly all of them, compared to only about 1/3 of non-HIV-associated cases.
This is where it gets truly captivating and offers a profound mechanistic insight for the deeper learner. In HIV-associated CHL, it's not just a correlation, it appears to be a direct cause. Imagine the Epstein-Barr virus, or EBV, almost like a tiny saboteur, sneaking into these specific cancer cells and flipping on a hidden switch a protein called latent membrane protein 1, or LMP1. This protein is typically associated with viral activity.
And further solidifying this, when researchers look at the EBV's genetic material within these cancer cells from multiple disease sites in the same HIV-associated CHL patient, they find that the viral genomes are episomal and clonal. This means the viral DNA is present as independent circular pieces within the cell nucleus, and critically, all the cells contain identical copies of the viral DNA. This strongly suggests that EBV was directly involved in the early foundational stages of lymphomagenesis, meaning the very first steps of cancer development in these specific cases. It's like finding the same unique viral fingerprint on every piece of a larger criminal blueprint.
That's a powerful illustration of the virus's direct involvement. Now let's move on to the enigmatic Reed-Sternberg, or HRS cell itself. This cell is truly the iconic signature of CHL. Histologically, meaning what pathologists see under the microscope, the presence of these particular cells is diagnostic of CHL.
These are large, distinctive cells. They have abundant cytoplasm material filling the cell and often possess bilobed or two-lobed nuclei or even multiple nuclei. And characteristically, they feature prominent nucleoli, which are dark, eye-like structures within the nucleus. They're quite striking once you know what to look for.
And their unique immunohistochemical profile is crucial for diagnosis. This refers to the specific markers or proteins expressed on their surface or inside the cell, which can be identified using special stains. They're typically PAX5 positive, which is a B-cell-specific transcription factor, but paradoxically, they show low to no expression of other common B-cell antigens like CD19 and CD20. But critically, they do express CD15 in about 85% of cases and CD30 in 100% of cases. These last two markers, CD15 and CD30, are the absolute hallmarks for pathologists confirming a CHL diagnosis.
What's truly paradoxical, though, given their immense diagnostic importance, is their sheer rarity within the tumor itself. HRS cells actually comprise less than 1% of the total tumor cellularity. This raises an important, almost counterintuitive question. How can such a rare cell, a tiny minority, effectively drive and sustain an entire malignancy?
It's not just a collection of cells, it's a truly sophisticated cellular symphony, or perhaps more accurately, a master manipulator and its orchestrated environment. The vast majority of the tumor mass isn't actually the cancerous HRS cells themselves, but a dense surrounding inflammatory infiltrate. We're talking about a diverse collection of polyclonal lymphocytes, eosinophils, neutrophils, macrophages, plasma cells, fibroblasts, and even collagen. These are all normal immune and structural cells recruited to the tumor site.
And this isn't just passive bystander tissue. The HRS cell actively, almost maliciously, interacts with this microenvironment. They engage in direct cell-cell contact, and even more importantly, they elaborate, meaning they produce and secrete a complex array of growth factors and cytokines. These are like chemical signals. This constant communication creates a protective cellular milieu, essentially a personalized shield that effectively cocoons the HRS cell and shields it from the host immune system's attempts to attack it. Moreover, the surrounding environmental cells, once recruited, then provide crucial cell signaling and cytokine production that actually promote the proliferation survival of the HRS cell itself. It's a vicious cycle where the cancer cell engineers its own protective and nurturing ecosystem.
This brings us to a critical insight for understanding newer treatments, the immune evasion mechanism. It's a fascinating biological trick. It's been discovered that an astounding 97% of HRS cells in CHL harbor genetic aberrations in a specific location on chromosome 9 called 9p24.1, which includes the PDL1 locus.
Right. This specific genetic alteration results in the significant overexpression of PDL1. Now, PDL1 is the ligand or binding partner for the inhibitory PD-1 receptor, which is found on immune cells, particularly T cells. Think of it like this. Your immune T cells are the attack dogs, constantly patrolling for threats. The PD-1 receptor is like a stop button on these attack dogs. When a healthy cell, or even a cancerous cell, flashes the PDL1 signal, it hits that stop button on the T cell telling it, don't attack me, I'm harmless, or at least don't worry about me.
So if I'm following, the Hodgkins-Reed-Sternberg cell essentially weaponizes this normal immune checkpoint. By overexpressing PDL1, it's constantly pressing the stop button on attacking immune cells, effectively putting them to sleep or turning them away.
Precisely. This overexpression of PDL1 is a key mechanism by which the HRS cell can actively evade immune destruction within its very own inflammatory microenvironment. It's a clever trick, using the body's own regulatory mechanisms against itself, and it also contributes to the generalized immune suppression often seen in patients with Hodgkin's lymphoma, making their immune system less effective overall. Understanding this interaction is foundational to the exciting advancements in immunotherapy we'll discuss later. It's about taking the brake off the immune system.
That detailed understanding of the Reed-Sternberg cell's clever tricks highlights just how sophisticated this disease is. And that sophistication carries right over into how doctors must approach diagnosing it. So let's talk about the medical detective work involved in pinpointing classical Hodgkin's lymphoma. The gold standard for establishing a diagnosis is the review of an adequate biopsy specimen by an expert hematopathologist. Their specialized expertise is absolutely critical here.
Because, as we discussed, HL is characterized by those rare neoplastic cells of B cell origin, meaning they come from those B lymphocytes, but their immunoglobulin genes are rearranged but not expressed, indicating they are abnormal. These cancer cells are then hidden within a tumor mass that is largely composed of a polyclonal inflammatory infiltrate. So it's like finding a few unique malignant needles in a haystack of normal immune cells, which are probably just reacting to the cytokines produced by the tumor cells. It demands a highly trained eye to differentiate the subtle clues.
This complexity means that differential considerations are extremely important. When a pathologist looks at a lymph node biopsy suspicious for HL, they must be able to distinguish it from a wide array of other conditions that can look similar under the microscope. This includes various inflammatory processes, mononucleosis, which also involves lymph node swelling in other non-Hodgkin's lymphomas, sometimes even a reaction to certain medications like phenytoin, which can cause swollen lymph nodes, and of course other non-lymphomatous malignancies. It's a true diagnostic labyrinth.
So, what does HL look like when a patient first presents in the clinic? The most common initial sign is palpable, non-tender lymphadenopathy, meaning swollen, painless lymph nodes. These are most frequently found in easily accessible areas like the neck, the supraclavicular area just above the collarbone, and the axilla or armpit. The disease often starts in one area and spreads.
And interestingly, more than half of patients will actually have mediastinal adenopathy, that's swollen lymph nodes in the chest area, specifically in the mediastinum diagnosis. Sometimes this can even be the very first manifestation of the disease, discovered perhaps on a chest x-ray for another reason. Conversely, subdiaphragmatic presentation, meaning lymph node involvement below the diaphragm, is less common initially and tends to be seen more in older males.
A significant hallmark, affecting about 1/3 of patients, are the systemic symptoms known as B symptoms. These are critical clues for clinicians. They include unexplained weight loss, specifically more than 10% of total body weight in a 6-month period, unexplained persistent or recurrent fever greater than 38 degrees Celsius or 100.4 degrees Fahrenheit for over a month, and recurrent drenching night sweats, often so severe they soak through bedclothes. These B symptoms indicate a more active systemic disease.
Beyond the typical B symptoms, HL can occasionally present in surprisingly unusual ways, which often pose diagnostic challenges. For instance, it can manifest purely as a fever of unknown origin, or FUO, where the only clue is a persistent, unexplained fever. This is more common in older patients who are later found to have mixed cellularity HL in an abdominal site where it's not immediately visible.
And rarely, the fevers can follow a very specific undulating pattern. They persist for days to weeks, then resolve for a period only to recur again. This classic waxing and waning fever pattern is famously known as Pell-Epstein fever.
And here's where it truly gets interesting. showcasing the disease's varied and sometimes surprising impact on the body, beyond just the obvious lymph node swelling. HL can present with severe and unexplained itching, or pruritus, which can be incredibly debilitating. You can also see various cutaneous disorders like erythema nodosum, which causes tender red nodules on the skin, and ichthyosiform atrophy, a rare skin condition. More profoundly, there can be paraneoplastic cerebellar degeneration, which impacts coordination and balance, and other distant central nervous system effects, even though the cancer isn't in the brain itself.
We've also seen nephrotic syndrome, a kidney disorder, immune hemolytic anemia where the body destroys its own red blood cells, and thrombocytopenia, a low platelet count, leading to bleeding issues. Sometimes patients experience hypercalcemia, an abnormally high level of calcium in the blood, which can cause fatigue and confusion, and even quite uniquely excruciating pain and affected lymph nodes upon alcohol ingestion, a rare but distinctive symptom that can be a telling clue for some patients. It's a truly diverse array of potential manifestations, making HL a master of disguise in some cases.
That's a comprehensive list of how HL can present. So the diagnostic workup for HL is clearly a systematic, multi-step approach. It always begins with a careful history and physical examination. This is foundational. As clinicians, we need to specifically ask patients about the presence or absence of B symptoms, as you mentioned, and thoroughly review any comorbid diagnoses they might have, such as pre-existing pulmonary disease or congestive heart failure. This is absolutely crucial because many of the chemotherapy drugs used can cause both lung and heart toxicity, so knowing a patient's baseline is vital for safe treatment.
The physical examination should meticulously focus on all peripherally accessible sites of lymph nodes, from the head down to the groin, palpating for any enlargement. A careful assessment of liver and spleen size is also vital, as these organs can often be involved in HL. The laboratory evaluation typically includes a complete blood count with differential to check for anemia or changes in white blood cell counts, and an erythrocyte sedimentation rate, or ESR. The ESR is a marker of inflammation, and an elevated ESR can indicate more active disease. We also perform comprehensive chemistry studies to reflect major organ function, including serum albumin, a protein that can be an indicator of overall health. And importantly, HIV and hepatitis virus testing are essential, as these co-infections can influence both the disease's biology and treatment choices.
When it comes to advanced imaging for staging, a positron emission tomography, or PET, combined with a computed tomography, or CT, scan is now crucial. This combined PET-CT is considered superior to a bone marrow biopsy for evaluating marrow involvement in CHL. Why? Because involvement in the bone marrow tends to be patchy, meaning the cancer cells aren't uniformly distributed, and a unilateral biopsy taking a sample from just one side could easily miss areas of involvement. A PET-CT, on the other hand, gives a whole body picture.
It's worth noting that the initial evaluation process for both Hodgkin's lymphoma and non-Hodgkin's lymphoma is quite similar in many ways. In both situations, determining an accurate anatomic stage is an extremely important part of the overall evaluation. This leads us directly to the Ann Arbor staging system, the universal language for describing the extent of Hodgkin's lymphoma.
The Ann Arbor staging system is truly the blueprint for navigating the disease's spread. Staging for CHL is anatomically based, reflecting the disease's classic propensity to spread in a very predictable fashion. From one lymph node group to an adjacent, often contiguous or connected group. It's like the disease prefers to move neighbor to neighbor rather than jumping randomly across the body.
And why does staging matter so much? It's absolutely essential for selecting therapy of the appropriate intensity we don't want to undertreat or overtreat. Although it's important to remember that for Hodgkin's, the outcome of optimal therapy is often excellent across all stages, meaning even advanced stages can be highly curable with the right approach. Patients are broadly stratified into early-stage disease, which typically includes stage 1 or stage 2, or advanced stage disease, meaning stage 3 or stage 4.
Let's break down the Ann Arbor stages in detail so you can truly understand the progression. Stage I is the most localized. It means involvement of a single lymph node region or a single lymphoid structure, like the spleen, the thymus, or Waldeyer's ring in the throat area. It's confined to one spot. Stage 2 signifies involvement of 2 or more lymph node regions, but importantly, these are all on the same side of the diaphragm. For example, lymph nodes in the neck and the armpit, but both above the diaphragm. Even if the mediastinum or chest area is involved, it's considered a single site. But if hilar lymph nodes on both sides of the chest are involved, that would elevate it to stage 2.
Okay. Stage 3 indicates more widespread disease, with involvement of lymph node regions or lymphoid structures on both sides of the diaphragm. This stage is further broken down for precision. 3.1 refers to subdiaphragmatic involvement, meaning below the diaphragm, limited to specific areas like the spleen, the splenic hilar nodes near the spleen, celiac nodes, or portal nodes in the abdomen. 3.2 means subdiaphragmatic involvement is more extensive. It includes periaortic, iliac, or mesenteric nodes, deeper abdominal nodes, plus any of the structures found in 3.1. This indicates broader abdominal spread.
And finally, stage 4 is the most advanced. This signifies involvement of extranodal site, meaning outside of typical lymph node areas beyond what's designated as E. E itself means localized, solitary involvement of extralymphatic tissue, excluding the liver and bone marrow. But in stage 4, it's more extensive. This includes more than one extranodal deposit at any location or any involvement of critical organs like the liver or bone marrow. That's when the disease has truly spread widely.
Beyond the numerical stage, we also use suffixes to denote symptoms or specific involvement, providing an even more detailed picture. A indicates the absence of systemic symptoms, meaning no B symptoms. B means the presence of those specific B symptoms, that unexplained weight loss of over 10% of body weight in 6 months, persistent or recurrent fever greater than 38 degrees Celsius, or recurrent drenching night sweats. These B symptoms are a crucial prognostic factor, and E means localized, solitary involvement of extralymphatic tissue, as we briefly mentioned. It's important to remember the suffix specifically excludes the liver and bone marrow, which, when involved, automatically push the disease into stage 4.
So with all that staging information, how do we prognosticate for these patients? For early stage disease, the prognosis is generally better, as you might expect. But even with an early stage, it's further classified as favorable or unfavorable risk. This classification is based on varying factors that can differ slightly from study to study, but typically include bulky disease, meaning a very large tumor mass, the number of lymph node areas involved, an elevated ESR, specifically greater than 30 if B symptoms are present or greater than 50 if B symptoms are absent, and the patient's age, with older age often being an unfavorable factor.
For advanced stage disease, where the disease has spread more widely, prognosis is best predicted by a tool called the International Prognostic Score, or IPS. This score is remarkably straightforward and powerful. It assigns 1 point for each of 7 specific factors. These are male sex, age greater than 45 years, having stage 5 disease, a serum albumin level less than 4 grams per deciliter, indicating poor nutrition or liver function, hemoglobin less than 10.5 grams per deciliter, indicating anemia, a white blood cell count equal to or greater than 15,000 per microliter, indicating high inflammatory response, and a lymphocyte count less than 600 per microliter and or less than 8% of the white blood cell count, indicating a suppressed part of the immune system.
The impact of the IPS is truly significant and helps tailor treatment intensity. For example, the 5-year progression-free survival, meaning the likelihood of disease not progressing or recurring within 5 years, ranges from a high of 88% for patients with no risk factors on the IPS, all the way down to 62% for patients with 4 or more factors. It's important to note, though, that very few patients actually present with multiple risk factors, which highlights the IPS's utility in precisely identifying those specific, higher-risk subsets who may need more aggressive initial treatment or closer monitoring. It's a powerful tool for stratification and patient counseling. Now, let's move into the strategic battle. The treatment approaches for classical Hodgkin's lymphoma. The overarching philosophy here is quite clear, and it's a direct reflection of that incredible success story we started with. The goal is nothing less than to cure the overwhelming majority of patients, primarily using either chemotherapy alone or a combination of chemotherapy and precisely targeted radiation therapy.
That's right, and a key distinction in treatment strategies diverges quite significantly based on the disease stage. For patients with advanced stage disease stages 3-3 or IV, it's been long appreciated through extensive research that they do not benefit from the addition of radiation therapy after achieving a complete response to chemotherapy alone. Adding radiation in this scenario just adds toxicity without improving outcomes. Therefore, these patients are effectively treated with chemotherapy only.
The standard regimen, particularly prevalent and highly effective in the United States, is ABVD. That's a powerful 4-drug combination: doxorubicin, bleomycin, vinblastine, and dacarbazine. It's typically given for 6 cycles over roughly 12 weeks, and its effectiveness has truly changed lives. We have, of course, evaluated alternative regimens over the years, like Stanford V and escalated B copy, which involve a broader, more intense mix of chemotherapy drugs. However, despite their intensity, these alternative regimens haven't been associated with an improvement in overall survival in advanced stage disease, and crucially, they come with significantly increased toxicity, meaning more severe side effects and a higher risk of long-term complications. So ABVD remains the benchmark standard for good reason.
For the small fraction of patients, typically less than 10%, who do not achieve a complete remission with chemotherapy alone, meaning they still have persistent disease activity as shown by a PET scan positivity, they may then benefit from the addition of involved field radiotherapy. This is radiation targeted precisely to the areas where the residual disease is located, effectively mopping up what the chemotherapy couldn't eradicate on its own.
Now, for early-stage disease stages Hodgkin 2, this is where we encounter the core controversy and an active area of debate in the field. The central dilemma for clinicians is truly about maximizing the treatment outcome, ensuring the highest cure rates while simultaneously minimizing those late therapy-related toxicities we discussed, especially by trying to avoid radiation therapy where possible. It's a delicate balance between aggressive cure and long-term health.
Historically, combined modality therapy, meaning chemotherapy plus radiation, has been associated with a small, statistically significant decrease in the risk of relapse for early-stage disease. However, it significantly increases the risk of those late toxicities we talked about earlier: secondary malignancies, thyroid disease, and premature cardiovascular disease and stroke. These long-term consequences often result in minimal or, critically, no improvement in overall survival compared to chemotherapy alone. The reason for this apparent paradox is that much of this long-term risk is specifically attributed to the radiation therapy itself, and for those who do relapse, excellent salvage strategies are often available.
Just to reiterate the standard for our reference, the ABVD regimen is given every other week, with each cycle typically including 2 distinct treatments. Now, for patients with favorable risk early-stage disease, what we call low risk, the use of 4 to 6 cycles of ABVD alone without any radiation therapy yields truly impressive progression-free survival rates of 88 and 92%, and overall survival rates of 97 to 100% at 5 to 7 years. That's astonishingly good with chemotherapy alone.
While this chemotherapy alone approach for favorable risk disease may be associated with a slightly increased risk of relapse compared to an abbreviated chemotherapy course, such as ABVD for 4 cycles, followed by involved field radiation therapy at a dose of 30 gingerly, there's no actual difference in overall survival between the two approaches. This is a critical point that the elite professionals truly grasp, and it's due to 2 key factors: the excellent salvage strategies available for relapsed HL, which can often cure those who do relapse, combined with the clear long-term benefit of avoiding those debilitating late toxicities seen after radiation therapy to the chest. It's a strategic choice for long-term patient health.
We've even seen German studies push this boundary further, examining a very abbreviated chemotherapy regimen. Just 2 cycles of ABVD, combined with low-dose radiation of 20 GD, but only for particularly good risk disease, meaning 2 or fewer lymph node areas involved. They found that this highly minimized treatment was equally effective as the standard combined modality therapy of ABVD for 4 cycles and 30 GZ of radiation. It's a testament to the ongoing effort to minimize intervention while maintaining that crucial efficacy.
Here's where it truly gets impactful in guiding clinical decisions: the crucial role of interim PT-CT scans. These scans are performed partway through treatment, and they can critically aid decisions regarding the duration and extent of therapy. They provide real-time feedback on how the cancer is responding. For example, one pivotal study showed that a negative PT-CT scan after just 3 cycles of ABVD predicted excellent outcomes with no additional therapy whatsoever. The patient could stop treatment early and still achieve a cure.
Similarly, another study found that a negative PT-CT scan after 2 cycles of ABVD predicted good outcomes with just 2 additional cycles of ABVD alone, without any radiation therapy. This clearly demonstrates risk-adapted therapy in action. It's about tailoring treatment precisely to the individual patient's response, avoiding unnecessary toxicity if the disease is melting away quickly while still ensuring optimal cure. It's a powerful application of imaging in modern oncology.
Now, for patients with unfavorable risk early-stage disease, the situation is a bit different, and the choices become more nuanced. The omission of radiation therapy following chemotherapy in these patients is associated with a more significant increased risk of relapse compared to favorable risk disease. So the risk of the cancer coming back is higher if radiation is skipped. However, crucially, and this is important to grasp, there's often still no change in overall survival because of the continued effectiveness and availability of those salvage options we just touched on.
So for these unfavorable risk patients, treatment options would typically include ABVD for 4 cycles, followed by involved field radiation therapy, that traditional combined approach, or ADVD alone for 6 cycles. The treatment decisions are frequently based on the extent of the radiation field needed and the specific unfavorable risk factor present. For instance, patients with non-bulky disease may still be candidates for chemotherapy alone if radiation is contraindicated for some other reason, like pre-existing lung or heart conditions.
Traditionally, combined modality therapy has been the go-to for patients with bulky disease, meaning a very large tumor mass at diagnosis. However, here's another example of evolving risk-adapted strategies. Even for patients with bulky disease, if they have a negative PT-CT scan after chemotherapy, they may not actually benefit from additional radiation therapy. This is a game changer, moving us towards even more personalized approaches based on how the individual patient's cancer responds.
And just to reinforce, when we talk about alternative chemotherapy regimens for early-stage disease, neither Stanford V nor escalated BCUP have resulted in improved outcomes in these patients, despite extensive evaluation. So again, while they exist, they haven't proven superior to ABVD, especially when considering toxicity. Now, let's talk about new horizons and navigating the reality of relapse in HL. While those cure rates are incredibly high, the reality is that relapse can happen for some patients after their primary therapy. But here's the good news, a message of true hope. Patients who relapse after primary therapy for HL can frequently still be cured. It's not a lost cause, far from it.
The challenge, however, is that patients who relapse after an effective chemotherapy regimen are usually not curable with subsequent chemotherapy administered at standard doses. The cancer cells have likely developed resistance. This necessitates a strategic shift, a change of tactics to overcome that resistance.
That's where salvage chemotherapy strategies come in. The purpose of administering alternative salvage chemotherapy regimens still at standard doses is twofold. First, to document the tumor's sensitivity to a different chemotherapy combination, seeing if it responds to a new set of gangs. And second, to achieve the maximum possible reduction of the tumor mass before moving to potentially more intensive curative treatments like stem cell transplantation. It's about setting the stage for the next phase of treatment.
Common regimens for this purpose include ICE, which is ifosfamide, carboplatin, and adipose, a powerful three-drug combination. Another is GND, which stands for gemcitabine, vinorelbine, and doxorubicin. We're also seeing incredibly promising early results with newer combinations that integrate targeted therapies, including brentuximab with either chemotherapy or breakthrough immune checkpoint inhibitors like nivolumab. These are exciting developments offering new pathways for patients who relapse.
And for patients with early-stage disease who don't respond sufficiently to salvage chemotherapy, radiation therapy can still be very effective in achieving a remission. The question of whether to consolidate such a remission with an autologous stem cell transplant, or ASCT, where a patient's own healthy stem cells are given back after high-dose chemotherapy, is still debated in this specific scenario. But the options are there.
This brings us to some truly breakthrough drugs for relapsed HL, which have revolutionized care. First, let's discuss brentuximab vedotin, known commercially as Adcetris. This is a fascinating targeted approach because it's what we call an antibody-drug conjugate. Think of it like a smart bomb designed for exquisite precision.
So if I'm understanding this, it's essentially two parts. An antibody that's programmed to specifically recognize and bind to CD30, which is a protein found abundantly on the surface of those Reed-Sternberg cells we discussed earlier. And then this antibody is chemically linked or conjugated to a potent chemotherapy drug, a microtubule inhibitor called monomethyl auristatin E, or MMAE. So that MMAE is like a tiny toxic wrench that jams the cell's internal machinery, preventing it from dividing and effectively killing the cancer cell, all delivered precisely by the antibody.
Precisely. It's a highly targeted delivery system. The antibody acts like a GPS, guiding the toxic payload directly and specifically to the CD30-positive cancer cells, minimizing damage to healthy cells. Early phase studies have combined brentuximab vedotin with doxorubicin, vinblastine, and dacarbazine, or AVD, for advanced stage HL, showing favorable efficacy compared to historical controls.
And the Echelon-1 trial, a truly pivotal randomized trial, compared AVD plus brentuximab to the standard ABVD regimen. It was a positive study, demonstrating an improvement in progression-free survival for AVD plus brentuximab, especially among younger patients, those from North America, and patients with higher risk disease. This has really changed the way many patients are treated up front.
In the salvage setting for patients who have relapsed, brentuximab vedotin can be a crucial tool. It can be tried as a bridge to an allogeneic transplant where stem cells come from a donor for advanced stage patients in whom salvage chemotherapy has failed. Furthermore, it's also used as maintenance therapy following a successful autologous stem cell transplantation based on results from a randomized trial that showed it significantly reduced the risk of relapse compared to observation alone. It's a versatile and powerful drug.
Now, let's talk about another revolutionary class of drugs that have truly reshaped oncology: The PD-1, PD-L1 axis inhibitors, often called immune checkpoint inhibitors. The rationale here is incredibly compelling, especially in HL, given that overexpression of PD-L1 on the HRS cell surface we discussed earlier. These drugs were specifically developed to boost the host immune recognition of tumors by removing the brakes on the immune system.
Think of it like this. Your immune T cells are the patrol cars, always looking for suspicious activity. The cancer cell has cleverly put up a do not disturb sign, PDL1, which signals to your T cell's PD-1 receptor to ignore it. These checkpoint inhibitors, such as pembrolizumab and nivolumab, essentially block that do not disturb signal. They take the brake off your T cells, allowing them to recognize and attack the cancerous Reed-Sternberg cells that were previously hiding in plain sight.
And these drugs have shown remarkable efficacy in the setting of relapsed disease, demonstrating very high response rates and, crucially, are associated with remarkably durable responses. Their role is continually expanding, and they are now being tested in conjunction with chemotherapy, both as salvage therapy for relapsed disease and profoundly in previously untreated patients, including in a multicenter randomized trial against AVD plus brentuximab as initial therapy for advanced stage disease. They're truly changing the treatment landscape.
This is where it gets truly fascinating for the deeper learner. Increasingly, there is an appreciation that checkpoint inhibitors don't just act as immune boosters. They also seem to restore the HRS cell's sensitivity to chemotherapy, even if the precise mechanisms are still unknown. This raises an important question that researchers are actively pursuing. What exactly is happening at the cellular level that allows these immune modulators to resensitize cancer cells to traditional chemotherapy, making them vulnerable once again? It suggests a complex interplay we're only beginning to understand.
And this sensitizing effect of checkpoint inhibitors has truly significant implications for autologous stem cell transplantation. It may become a potentially curative option, even for patients previously considered to have chemotherapy-resistant disease, transforming what was once a dead end into a pathway to cure.
We also have other options in the setting of disease relapse after initial ABVD chemotherapy. Alkylating agent-based combinations like CHL-VPP, which is chlorambucil, vincristine, prednisone, and procarbazine, may be active in patients with disease resistant to ABVD. In addition, for the rare instances of relapse following a bone marrow transplant, sometimes even weekly low-dose single-agent vinblastine can be remarkably effective. So the arsenal for managing relapse is diverse and growing.
We've talked about the incredible triumph of curing Hodgkin's lymphoma, transforming it from a death sentence into a highly treatable disease. But now, we must confront the paradox of survivorship. Due to the very high cure rate in patients with HL, long-term complications have become a major focus for clinical research. It's a testament to our success, but also a new frontier of challenges in ensuring not just life, but quality of life.
And here's a sobering fact, a critical insight for you to grasp that underscores this paradox. In some patient series, especially those treated in earlier eras with more aggressive therapies, more individuals with early-stage disease actually died from late complications of therapy than from HL itself. This is particularly true for patients with localized disease, underscoring the immense importance of meticulously monitoring and managing these long-term effects. The most serious late side effects include secondary malignancies and cardiac injury.
Let's delve into secondary malignancies first, meaning other cancers that develop as a consequence of the treatment. Patients are at risk for developing acute leukemia, typically within the first 10 years after treatment, especially with combination chemotherapy regimens that contained alkylating agents plus radiation therapy.
The risk for acute leukemia is notably greater after the older MOPP-like regimens, which included meclorthamine, vincristine, procarbazine, and prednisone, and also Biacup-like regimens compared to the modern standard ABVD. This is a significant advantage of ABVD. The risk is also directly related to the number of exposures to potentially leukemogenic agents, for example. If a patient undergoes multiple treatments after relapse, and it's also linked to the patient's age, with those over 60 years old at particularly high risk.
And carcinomas, solid organ cancers like breast, lung, or gastrointestinal cancers are a major problem that typically emerges much later, usually 10 or more years after treatment. These are very strongly associated with radiotherapy, particularly to the chest. This is precisely why screening and prevention are so critical for survivors. Young women treated with thoracic radiotherapy, for instance, should institute screening mammograms 5–10 years after treatment, much earlier than the general population. And crucially, all patients who receive thoracic radiotherapy for HL should be strongly discouraged from smoking due to the compounding risks involved, Combining radiation exposure with smoking dramatically increases the risk of lung cancer, for example.
Beyond secondary cancers, cardiac injury and cardiovascular disease are also significant long-term concerns for HL survivors. Mediastinal radiation, which is radiation to the chest area, significantly accelerates coronary artery disease, leading to earlier heart attacks, heart failure, and other cardiovascular issues. Therefore, patients should be strongly encouraged to minimize all modifiable risk factors for coronary artery disease, such as quitting smoking, managing elevated cholesterol levels, and controlling blood pressure. These lifestyle interventions become critical components of their long-term care plan.
And cervical radiation therapy, specifically to the neck area, can increase the risk of carotid atherosclerosis, a hardening of the arteries in the neck which can lead to an increased risk of stroke. It also raises the risk of thyroid disease, including both benign thyroid dysfunction and, less commonly, thyroid cancer. These are not minor side effects. They require careful, lifelong monitoring and management.
A number of other late side effects from the treatment of HL are also well known and require ongoing vigilance. Patients who receive thoracic radiotherapy are at very high risk for the eventual development of hypothyroidism, meaning an underactive thyroid gland. They should be observed for this complication, and intermittent measurement of thyrotropin, or TSH, levels should be made to identify the condition before it becomes symptomatic and affects their energy and metabolism.
Another notable, though often temporary neurological side effect is Lymphoma syndrome. This occurs in approximately 15% of patients who receive thoracic radiotherapy, typically a few months after treatment. This syndrome manifests as a distinct electric shock sensation that travels into the lower extremities upon flexion of the neck, like when you bend your chin to your chest. While it can be disconcerting, it usually resolves on its own over time.
And given the young age at which HL is often diagnosed, infertility is a major, often devastating concern for survivors. Infertility occurs in nearly all men treated with alkylating agent-containing chemotherapy, as these drugs can severely damage sperm-producing cells. For women, the risk of permanent infertility after treatment with alkylating agent-containing chemotherapy is largely age-related, with younger women generally more likely to recover fertility compared to those closer to menopause. Crucially, and this is a significant advantage, infertility is very rare after treatment with ABVD alone, which is a major reason it's the preferred regimen when possible, especially for young patients who desire to have children in the future.
All of this underscores the imperative of long-term follow-up. There's an ongoing, lifelong need for medical follow-up for Hodgkin's lymphoma survivors, not just to check for recurrence, but critically, to monitor for and manage these potential long-term complications. It highlights the truly holistic approach required for modern cancer care, an approach that extends far beyond the initial cure and focuses on the entirety of a patient's life. Now let's turn our attention to the distinct entity we mentioned earlier, nodular lymphocyte-predominant Hodgkin's lymphoma, or NLPHL. This is a crucial clarification that the elite professionals truly understand. It is now recognized as an entity entirely distinct from classical Hodgkin's lymphoma. While it shares the Hodgkin's name, its behavior and biology are fundamentally different.
Historically, earlier classification systems did note that biopsies from a small subset of patients diagnosed with what was then called HL contained a predominance of small, normal-looking lymphocytes and very rare Reed-Sternberg-like cells. Critically, these tumors exhibited a distinct nodular growth pattern appearing in clumps rather than diffuse spread, and most importantly, a clinical course that varied significantly from CHL. Today, this unique combination defines NLPHL. It's a relatively unusual clinical entity, representing less than 5% of all Hodgkin's lymphoma cases.
What's truly interesting and a key insight into its distinct nature is its close relationship to non-Hodgkin's lymphoma, or NHL. The HRS-like cell in NLPHL is actually quite different from the CHL Reed-Sternberg cell. It's called the lymphocyte and histiocyte, or LNHL, which is affectionately known by pathologists as a popcorn cell due to its irregular convoluted nucleus that can resemble popcorn. And crucially, this popcorn cell is a clonal proliferation of B cells, indicating its B cell lineage directly.
And this is a critical distinction for professionals. The immunophenotypic differences are absolutely key for diagnosis. LNH cells are positive for a range of B-cell markers, including CD45, CD79A, CD20, CD19, and BCL2. But crucially, they do not express CD30 and CD15, which are the characteristic defining markers of the HRS cells in classical Hodgkin's lymphoma. This immunophenotypic fingerprint is a major differentiator and points to NLPHL's distinct biological nature.
Their clinical course also strongly resembles NHL more closely than CHL. This lymphoma tends to have a chronic relapsing course, meaning it can come and go over many years, often requiring multiple treatments over a lifetime. And importantly, it can sometimes transform into more aggressive lymphomas, specifically diffuse large B-cell lymphoma, including a particular subtype known as T-cell histiocyte-rich B-cell lymphoma. This natural history, particularly its chronic relapsing nature and potential for transformation, most closely resembles that of the indolent or slow-growing B-cell NHLs.
Looking at the epidemiology and clinical presentation of NLPHL, it disproportionately affects males, accounting for about 75% of cases. Like CHL, the age distribution of patients with NLPHL has two peaks. However, distinctively, these peaks include children and young adults, often aged 30–40 years, which differs slightly from the bimodal distributions seen in CHL.
The majority of patients with NLPHL, about 75%, are diagnosed with early-stage disease, typically stage I or II, with only a minority having advanced stage disease at initial diagnosis. And unlike CHL, those characteristic B symptoms, the unexplained fevers, drenching night sweats, and significant weight loss are uncommon in NLPHL. This further highlights its more indolent and less aggressive presentation compared to CHL.
Now, the treatment approaches for NLPHL present an area of significant nuance and ongoing debate among clinicians. For patients with early-stage disease, meaning stage I or high at diagnosis, definitive radiotherapy to the involved areas is generally the recommended treatment. This approach is associated with an excellent long-term prognosis with a 15-year non-relapse survival rate of 82%. So for localized disease, radiation is often curative.
However, the treatment of patients with advanced stage NLPHL is quite controversial, and this is where that nuance truly comes into play. Some clinicians actually favor no immediate treatment for asymptomatic disease, instead opting for careful, close follow-up essentially, a watchful waiting approach. This is quite similar to how some indolent B-cell non-Hodgkin's lymphomas are managed, acknowledging their slow-growing nature.
For patients who do need therapy due to symptoms, such as significant lymph node enlargement causing discomfort or signs of organ function impairment, clinicians have a choice between two main types of regimens, both CHL regimens like the familiar ABVD and B-cell NHL regimens, including RCHOP, which is rituximab, cyclophosphamide, doxorubicin, vincristine, and prednisone have been used with success. The choice often reflects the clinician's understanding of its NHL-like characteristics.
One particular single-institution experience with RCHP showed promising results for advanced NLPHL, resulting in a 100% response rate in a small group of patients, with no relapses observed at 42 months of follow-up. Now, we must acknowledge that while this is certainly an impressive result, 42 months is considered relatively short follow-up for an indolent disease like NLPHL, which by nature can have a long, slow, relapsing course spanning many years.
Yet, based on such promising early data, some clinicians believe that RCHP may indeed be curative in this disease and therefore advocate for treating advanced stage patients at diagnosis, regardless of whether they have symptoms or organ impairment. This raises an important question that specialists constantly grapple with. How do we weigh early, promising results, even if from a small study, against the known long-term, often relapsing course of an indolent disease like NLPHL? It's a delicate balance clinicians must constantly consider, and it highlights the ongoing evolution of best practices in this rare subtype.
We've truly gone on a deep dive today, haven't we? From the incredible, inspiring journey of Hodgkin's lymphoma, transforming from a largely fatal disease in the mid-20th century to one with astounding cure rates today, we've unpacked its intricate biology, revealing the enigmatic Reed-Sternberg cell and its clever immune evasion tactics.
We've explored the precise diagnostic and staging methods that guide treatment, like the Ann Arbor system, and navigated the evolving treatment paradigms for both early and advanced stages, understanding the delicate balance between aggressive cure and minimizing long-term toxicity. And of course, we've delved into the exciting new therapies on the horizon, from antibody-drug conjugates to immune checkpoint inhibitors, which are truly revolutionizing care for relapsed disease.
And crucially, you now have a clear understanding of the often overlooked distinctions between classical HL and its more enigmatic cousin, nodular lymphocyte-predominant HL, grasping their unique biological and clinical characteristics. You now have a solid understanding of this complex area, grasping the nuances that define its diagnosis, treatment, and long-term implications, just like the elite professionals in this field.
You understand why the Reed-Sternberg cell, despite its rarity, is so central to CHL, and how that unique microenvironment plays such a critical role in immune evasion driving the cancer's survival. This understanding is key to future breakthroughs.
But here's a thought to mull over as you reflect on this deep dive. As oncology continues to achieve higher and higher cure rates for cancers like Hodgkin's lymphoma, the focus increasingly shifts from simply eliminating the disease to ensuring a long, high-quality life free from treatment-related complications. It's not just about surviving, it's about thriving.
So, consider what might be the next frontier in cancer therapy, beyond just the cure of the immediate disease, that truly redefines what being well means for survivors, not just in the short term, but for decades to come. It's a profound challenge that drives much of the research and innovation in cancer care today.
Keep that curiosity alive.
Thank you for joining us on this deep dive.